Manasi?
Yeah, ma'am, this is Bhavesh here.
Yeah, Bhavesh, can you just disable the chat, please? Keep the question and answer on. Disable the chat. Otherwise, that will be all over the place.
Yeah.
Keep the question and answer on, but disable the chat, please. Okay?
Yeah, sure.
Thank you. Hi, Anita.
And the chat is only between the panelists. It is not for the participants.
Okay, wonderful. Thank you. Anita?
Hi, madam.
Hi. Would you like to just share one of your slides so that we know that
I'll do. Just give me half a minute. I'll do.
Yeah.
Okay, I'm just going to share my screen. Yeah.
Sure.
You can see my screen now?
Yes.
Great.
You
So
can go full screen.
I'll just play the slideshow there are no videos or anything, so I don't think there'll be a technical issue.
Yeah.
But I'll just, so you're able to see that,
Perfect.
right?
Yes, perfect.
Great. So I'm just going to stop sharing.
Great. Thank you, Anita.
Most welcome. Okay, great. Sorry, one more thing. Am I audible, or do you think I need to use the microphone with the earphones?
No,
What do you
you're
think?
audible.
Currently, your voice is fine. No problem.
Perfect. Thank you so much.
Bhavesh, only thing is perhaps everyone should put off their mobiles or at least put them on silent. Otherwise, that you keep getting an echoing.
Yes.
That'll be nice.
Sure. Ma'am, I have not opened it as yet for participants. We still wait for another 3-4 minutes and then open. Ma'am, you're not audible. You're muted.
Yeah, okay. No, we open it up about 5 minutes or 10 minutes prior to 4 o'clock. Yeah.
Okay.
People will start coming in.
Yes.
Quite a few of our MSPs are members they take time and they get a bit agitated. So perhaps you could open it up. It's
Ma'am, you got muted.
at about another 3 minutes, and then you
Okay,
can.
sure.
Yeah,
Sure.
yeah.
So we are not able to hear you. If you could just speak, we can check your mic.
Who's mic, Bhavesh?
Fitness.
Okay, Sandeep. Yeah.
Yeah. So you're not audible as yet. No, can't hear you. Can't hear you at all.
Can you hear me now?
Yes, now we can.
Okay, it's perfect.
Yeah, this is okay. No problem.
No problem. No?
No problems.
Yeah, because I'm removing the handset.
Yeah, many times that connection is not very proper, then you don't get the volume at all.
Okay. Hello, everybody.
Good evening, everybody.
Good
Good
evening.
afternoon.
Hello, sir.
Good afternoon, your perspective. Good evening, my perspective.
Yes.
Good evening, everybody.
We know what we mean. The speakers are not yet here.
Anita is here. I can't see Geeta.
About 9 minutes. I'll just share the screen and then open it for the participants.
Sandeep, share your screen if you have slides.
I have
to
nothing.
share.
I have nothing to skip.
I think this sidebar, because it comes up, that is why Dr. Katrak had asked us to, get off the video as well as the audio, because the sidebar comes in on when the screen is being shared.
No, but Rekha,
And that
anyway,
you can.
this part, even if you switch off the video, it will remain as a black part.
Okay, right.
That is why I think, can't we reduce the size of the screen for the slides?
Sir, what you are seeing, you can change your view, sir.
Okay.
Where you are getting this all the videos.
How do I change my view?
At the top of that box, the 5-6 boxes which you are seeing, over that, just at the top, you will have that one small line, then one single box and multiple boxes.
That dotted thing.
Yes, if you
Nine dots. Okay.
From there, you can change your view. What participants would be seeing would be the entire screen, and to the right, just the speaker whoever is speaking. They will not see this.
Fine. Let me just try it out. Huh?
Yes, I've done that. That's great. That's great.
Yeah, it does that way, but nevertheless, Multiple Sclerosis Society of India, then whatever is into brackets is just not seen.
So that is just your view, sir. You can change the view.
Okay.
Participants are not seeing it that way.
All right, fine. What are the two lines? Show thumbnail video. Okay, fine. All right.
We've gone live and participants are joining now.
I think when the speaker comes,
Yes, sir.
I think that first second square, from the left hand side, we have a dash, then a blue square, then an equal sign, and then multiple windows, right?
Right.
I think we should press that only that blue thing so that only the speaker's video is on.
That's right. So
We
that
should
gives you
switch
only.
off our videos.
Yes.
Switch off our videos and mic. So that the broadband width is dedicated only to the speaker and the,
So once the presentation starts, I will do that from my end. No.
Okay, fine. Just do it from your end. Fine.
Yes.
But if we want to come in, then we have to wait for you to bring us in.
As soon as the screen share is stopped, I will activate everyone's video.
Okay, fine.
But you want to do it at your end, so you also can stop your video.
I can do it at my end.
Yeah, sure.
I just wanted to check my audio. Is it okay?
Yeah, it's fine. It's fine, sir.
Are you on the computer's audio only?
Yeah, I am on computer.
Fine. Sheila has not joined. That was also very clear, Sandeep. Huh? In this era of COVID, you shouldn't be coughing. We've got 4 minutes to go.
5 minutes.
Bhavesh, how many participants have joined already?
We have total 27, sir, right now.
Small number. Is Anita ready with her slides? Sandeep, you don't have any slides, no?
No, I don't have any slide.
So is Anita ready with her slides?
Yeah, we've checked that, sir. We've done that.
Sir, she shared them with us.
Yes, sir, I'm ready. It's all sorted out.
Fine, fine. Thank you.
I think so. I'll start the session. It's 4 o'clock.
Yeah.
Yes, please.
Yeah. So, namaskar. I'm Dr. Rekha Bhatkhande, and I welcome you all to the second webinar on hosted by the Mumbai chapter of MSSI in celebration of our 35th anniversary year of the Multiple Sclerosis Society of India. Today is also our 74th Independence Day. Our nation is celebrating that, so greetings on that too. Now, the topic for this webinar is urinary problems and Gynaec disorders in persons with multiple sclerosis. I welcome our chairman, Mr. Sandeep Chitnis, and very eminent neurologist, Dr. Sarosh Katra. Our speakers, Dr. Anita Bapat Patel and Dr. Geeta Balsarkar. I think she is yet to join us. And I also, I've been noticing the list of participants, so I welcome all the, all our representatives from our headquarters and other chapters of our across our country, our MSSI chapters. Now, I would like all of you, before we start this whole thing, is to say hello to our founder member, Mrs. Sheila Chitnis. She said she's not going to say a word, but all of us are here to say hello to her. We have a lot of words to say to her. So hello, Sheila, and this is your baby, and we're taking it forward. Now, Mr. Sandeep Chitnis is the National Vice President of and the Chairman of MSSI Mumbai chapter. He's a very busy CA and and is a partner in a renowned CA firm. He is a director on many prestigious companies and was the past president of the Rotary Club of Shivaji Park, Mumbai. Sandeep, I invite you to tell us about MSSI and about the working of our Mumbai chapter. Please go ahead.
Thank you, Dr. And I welcome everybody for the twin benefit of the twin relevant thing. First of all, we are celebrating our Independence Day, and another thing is that we have been celebrating our 35th anniversary of MSSI in a grand manner by doing various programs for the benefit of MS patients. So let me tell a little bit about Multiple Sclerosis Society of India, that is MSSI. We started with humble background, with only 3 patients and a few dedicated promoters, or you can say the founders. Out of that, we are fortunate to have Mrs. Sheila Chitnis, one partner, founder, who has been dedicatedly serving this society for past 35 years. Afterwards, we started growing. Now we are having 8 chapters for head office in Mumbai, and the rest of 7 chapters are in Bangalore, Chennai, Delhi, Indore, Hyderabad, Kolkata, Pune, and we have been growing considerably. Most important thing is, ours is the only society in India which is looking after multiple sclerosis patients' welfare, and ours is the only society which is affiliated to multiple MSIF, that is Multiple Sclerosis Society International Federation, which is a conglomeration of all multiple sclerosis societies across the world. We have been doing various things for the benefit of MS persons. First of all, let me tell more about our society. Our society is properly registered with the FCRA, and it has been compliant all throughout with all the other laws and laws of India. Another thing is that our society's specialty is all the managing committee of all the chapters across India are serving without any remuneration. They are all honorarily serving for the benefit of the MS patients. And we have been providing various facilities for MS patients. That is, the most important thing is when they are when they are diagnosed with MS, they require a lot of emotional support. So we have been giving them emotional support. Then we are looking after maximum type of possible welfare of MS patients by way of, let it be financial, let it be providing various services like home physiotherapy, occupational therapy, then conducting various medical camps under one roof, we are giving them services for all the various doctors from various all the fields are available at these medical camps, and that has been we have been providing that from years to years. Again, we have been giving them financial aid for them as well as their family members, mostly for education, and even sometimes starting off of the any enterprise. We have been looking at rehabilitation of the various multiple sclerosis patients. So with this, I would like to start our today's session, and I'm requesting Dr. Rekha to take it forward.
Thank you so much, Sandeep. And now I would like to introduce our guests of the afternoon, evening, Sir said. Okay, that is our clinical chairman, Dr. Saroj Katrak. He is one of the senior most neurologists in Mumbai. He's a director and professor emeritus of Neurology Department of Jaslok Hospital, Mumbai, and the professor emeritus of Grand Medical College and the JJ Group of hospitals. A while back, when WHO redefined the International Code of Diseases, that is the ICD-10, Dr. Saroj Katrak was invited to give his suggestions about the inclusion of neurological diseases in this code. I think that's a great honor, sir. So I hand the mic over to you, and please take this seminar forward.
Good afternoon, everybody, and welcome to this webinar organized by the MSSI. Today, we have two eminent speakers, and the first eminent speaker is Dr. Anita Bapat Patel, who has done her MCH, DNB, and FRCS, and is a consultant urologist at the Endoscopic Clinic and Hospital at Shivaji Park and Global Hospital at Parel. She did her undergraduate and postgraduate studies at the Lokmanya Tilak Medical College and Sion Hospital, and after obtaining her degree in urology, worked at the KEM Hospital initially as a lecturer and subsequently as a brief stint as an associate professor. Between October 1992 and July 1997, for a period over 5 years, she worked in the UK as a senior registrar in the North Yorkshire region with special interest in lower urinary tract dysfunction. And I'm very happy that today she is going to talk on urinary tract problems in MS. Over to Dr. Anita Bapat Patel. Thank you.
Thank you so much, sir, for the kind introduction. Am I audible?
Yes, please.
And
yes,
my
please.
slides are seen, right?
Yes.
Yes.
Lovely. Thank you so much. At the outset, I wish to thank the Multiple Sclerosis Society of India, especially the Mumbai chapter, for considering me worthy to be one of the faculty in this webinar. And I also bring greetings to everybody for Independence Day. Urinary issues in multiple sclerosis is a topic in itself, and I'm going to try my level best to kind of squeeze it into the next 15 minutes or so that we can spend some time in question answers. I presume all the audience members know what multiple sclerosis is all about, but a very simplistic definition would be it's a disease characterized by patchy loss of myelin cover on nerve fibers, both in brain and in the spinal cord. there is a higher preponderance of women, and the disease, as it affects various systems in the body, it obviously affects the urinary tract as well. So before we start talking about how it affects the urinary tract, let's understand what is normal urinary system. So I would call it a happy urinary system. This is a line drawing, my attempt at a line drawing of a happy urinary tract, which consists of two kidneys, the tubes connecting the kidney down to the bladder, called the ureters, and the lowermost part, which is the smiley in the picture, which is the urinary bladder. At the bottom of the urinary bladder is where the controlling muscles are located, both in men and in women. Let's see what an unhappy urinary system would look like. If there is any kind of bladder dysfunction or an abnormal behavior of urinary bladder, and in fact, which is what we are going to talk about today, it affects the entire urinary system. So the kidneys, in theory, can get affected, and the head of the family, which is located at the bottom in urinary tract, which is the urinary bladder, is what controls the rest of the urinary tract. We will see how it does that. While we're talking about multiple sclerosis, we cannot forget that men and women, especially the lower urinary tract, is made differently. So the disease affects different aspects of the urinary tract in both the sexes. The normal urinary bladder has two functions. It's a dual function. It stores urine and it empties urine. But both of these happen at will. So, for example, a normal person can store urine for as long as he wishes, without any discomfort or without any leakage. And this is irrespective of how vigorous physical activity he or she may be doing, whether you are hanging upside down, anything, there should not be leakage of urine. However, we all are aware that the bladder is getting filled up, and at some stage we are compelled to listen to the urinary bladder. The same bladder is also like a magical organ, able to completely empty itself, again in an effortless manner, in a flow which is steady, uninterrupted, and without any pushing by the person who's emptying the urine. And we are able to do that irrespective of how full the bladder is. For example, if you want to go out somewhere, even if the bladder has only 5 ml of urine, we would be able to empty it. And the same bladder can hold up to 600 ml, 700 ml and empty the entire content, again, effortlessly. And there is, of course, neurological control involved. And we don't have to go into the details of this, but we all know there is an autonomic nervous system consisting of sympathetic and parasympathetic nerves. And it's the sympathetic system which is involved in storing the urine, and it is parasympathetic system which is involved in peeing, that means passing urine. And the entire control mechanism is first coordinated in the spinal cord, modulated by a structure called pons in the region of brain. And finally, we get the finer control, which is the human angle to urinary control, and that is with the help of the topmost part of the brain called the frontal lobes. Even in MS patients, we can't forget that certain changes happen with age. So if a patient with MS has urine complaints, it's not necessary that they are due to MS alone. They could be a part and parcel of aging. And this we must particularly remember in women, because we all go through certain changes as a result of menopause. So how does MS affect urinary tract? Well, it produces two types of symptoms. And that is, produces storage symptoms and it produces emptying symptoms. That means symptoms referable to the two main functions of the urinary bladder. The common presentation in MS patients is storage symptoms. So what are the storage symptoms? That means the person will pass urine more frequently, with a degree of urgency, with or without leakage. And this can happen in up to 70% of patients. As against that, those who have difficulty emptying, this is relatively less common, but seen up to 40% of patients, they will struggle to empty the bladder at will. That means they will go to the washroom and wait for a while for the urination to actually start. Not only that, it will not be an effortless free flow as I described earlier, but it would be a stop and start mechanism. Why does this happen? Well, as we know, the signals are broken in multiple sclerosis patients. So when the bladder sends a signal, in MS patients, it sends a signal even when it's not very full. The brain also doesn't process it normally, but if it does, it will signal the bladder to stop the urine, but the signals don't reach the urinary bladder. So as a result, the brain and bladder are no more talking to each other, or if they are, they're talking in a staccato or broken manner. So by the time the brain is ready, the bladder may have finished the job. Or by the time the brain says, go, you can pass urine, the bladder may have become quiet. The urinary bladder also has a trap door, as I mentioned before, at the bottom of the urinary bladder that is called the sphincter. And in some MS patients, the sphincter or the door does not open free, even when the brain is asking us to. So it's a battle between the bladder trying to store and a bladder trying to empty, and one or both of these can get affected, sometimes associated with bowel issues. So MS patients will also have a variable degree of constipation or sometimes bowel hurry. That means they may land up rushing to the washroom to pass their motion with a fear of soiling their clothes. Where is the issue with all of this? Well, if one has bladder related issues, there is higher possibility of infections, slightly higher possibility of urinary stone formation. I'll tell you why this happens. If any water anywhere in the environment is stagnant, it will catch germs. So if our building drainage system, for example, is choked up, we will start growing mosquitoes. Same thing happens in bladder. So MS patients, particularly those who have a tendency to leave behind what is called as residual urine, they have higher chance of developing germs leading to urinary infection. Similarly, if there is stagnant pool of urine, there is a higher possibility of crystals developing in urinary tract. So there is a higher possibility of stone formation. Despite both of these, a serious or a permanent damage to the kidney, interestingly, is usually not seen in MS patients, which also means the urinary issues mainly impact the quality of life and are almost never life-threatening. What are the quality of life issues? First and foremost is social life. All our outings, if we happen to be an MS patient, would revolve around availability of toilets in the area. That would also mean we will reduce the liquid intake because I don't want to use the toilet. I'm not so sure how clean it may be. And I may have issues in my ability to use the toilet efficiently because of the MS. How does it impact the personal life? Well, first and foremost, if you suffer from frequent urination with leak, there is a fear of smell, a bad smell of urine. Also, we have to necessarily use the washroom frequently, even at home. And then we may take too long to empty the bladder. The same thing can impact our personal life. And last but not the least, let's not forget the financial issues, which is also a quality of life issue. So MS patient is far more likely to consult the doctor for urinary related problems. So it will involve doctor's fees, the cost of various things like catheters, diapers, medications, investigation. The list is endless. What can you do as a patient to get out of it? It's an Independence Day, and we're going to talk about how can we free ourselves from this web? How can we become independent? The first step is talk to the family members. Tell them that it's not just MS or the mobility related issues or the other aspects, but yes, there is a urinary problem, whatever the problem may be. If you're in an employment, talk to your employer because it may mean you being given breaks during your workplace to use the washroom more frequently, or certain different kind of facilities being made at your workplace specifically for you. Talk to your colleagues so that they will look at you with empathy and there wouldn't be any stigma associated with that. And of course, talk to the caregivers. Some of you may be very, very heavily dependent on caregivers, and that would involve the caregiver either putting a catheter or changing a diaper. So talk to them. Last but not the least, talk to your doctors. So when you talk to the doctor, what do the doctors do? If a patient comes to me, of course, I will listen to the patient. I will examine the patient, and I might order certain tests. The tests are usually simple. A simple urine test, a sonography, which tells us how full the bladder is, In a male, it will also tell us if there is an enlargement of the prostate. In a female, it will simultaneously tell us if there is any associated gynecological issues. It may pick up kidney stones, and the doctor will ask you to keep a bladder diary. A bladder diary is a documentation of how frequently you pass urine and how much do you do each time. And that actually is a mirror of the behavior or otherwise of our urinary bladder. In selected patients, we will do a specialized test called either a flowmetry, whereby we measure the flow on a machine, or a detailed evaluation using catheters connecting the patient to a computer called urodynamics, which will be required in a selected number of patients. So let's assume that we've done the evaluation and we have confirmed that this particular bladder has issues about storage of urine. How can you treat them? A very simple thing involves change in lifestyle. What kind of change? Well, first and foremost, alter the liquid intake, both in quantity and quality, because some of the liquids may be involved in making your bladder go more often. Also, sometimes when you go out, you don't want to drink liquid because otherwise that will make you go more frequently. And also the food habits, which means having dinner early, giving a nice gap between your dinner time and bedtime, so that that will reduce the nighttime urinary frequency. It also involves training the bladder to empty at fixed interval. For example, if I've had a cup of tea at say 10 in the morning, I would ensure that I develop a habit to visit the washroom at 11, roughly about 45 minutes to an hour after the last major liquid intake, to ensure that whatever urine that is there is empty. So I am kind of self-disciplining the bladder. We call it bladder drill. We sometimes have to customize special toilets in some patients who may have a severe sense of urgency, may not be able to reach the washroom. They can actually have a customized toilet next to their work area or to their bed, so that there is no issue of leaking on the way. And in general, improving activity level will help in holding the urinary bladder better. All of MS patients, especially those with storage urinary symptoms, respond to pelvic floor muscle training. And this is a systematic training which involves tightening the muscles, both of the motion area and the urinary area, usually under the supervision of a physiotherapist, and sometimes using gadgets such as electrical or magnetic stimulation to help us identify the pelvic floor and to tighten the pelvic floor muscle. This in turn can actually inhibit or abort the bladder contraction, and that definitely helps in improving the urine control. This is the first step in bladder control treatment in MS patients. Some of the MS patients will require usage of medication. Most commonly used medications are oxybutynin, tolterodine, and solifenacin. All of them fall under the generic term antimuscarinics, with oxybutynin having additional direct effects on the urinary bladder. The advantage is that most of these are once-a-day medications, so easy to remember. They are highly efficient in controlling and reducing the urinary frequency and often abolishing the leakage, though there's nothing like a free meal. So these tablets do have a degree of side effects, that is mainly dry mouth and constipation. So if you are constipated, you have to alert your doctor that, yes, I tend to have constipation, in which case they will change the medication to another suitable group, and that is beta-3 stimulants. Nowadays, we've started using them in bladder-related issues for MS. What about those who, despite medication, just cannot hold? Well, there are excellent diapers available. There are bed protectors available. And there are, of course, non-slip mats. And I strongly recommend all MS patients to have a non-slip mat on their way to the washroom. For those who have to use a diaper, make sure you use a barrier cream, because otherwise you will end up having a skin rash and very rarely a pressure sore or an ulcer simply because of a moist diaper. Those who can't empty the bladder, intermittent self-catheterization is a very easy option. We'll talk a little bit very shortly. Should you develop infection, antibiotic would be the way forward. So in a nutshell, this slide tells you how we educate the patient. We teach them how to inhibit the urge, how to modify their lifestyle, how to train the pelvic floor, and we periodically reinforce that with the help of a bladder diary. And all of this, of course, involves educating the patient and the caregivers and the family. So, talking about intermittent catheterization, on the right half of the screen, you will see simple things such as a plastic catheter, a pair of gloves, a xylocaine jelly, either tube or a liquid which is available in a bottle, and sometimes a disinfectant called betadine is required in some patients. Usually simple cleaning of urinary area is all that is required. A lubricating cum local anesthetic gel is applied to the tip of the catheter, and a nurse or your doctor will teach you exactly how to put the catheter, which can be a little tricky in women, but trust me, anybody and everybody can learn it. We in our practice in urology often teach small children also to put a catheter, though they don't have MS, but due to some other condition. I've also shown a typical adult diaper. The better ones are the ones which are pull-ups, because MS patients may have so much urgency, and some patients actually insist on pulling down the diaper and using the commode, in which case a pull-up kind of diaper is far better. Talking about self-catheterization, either the patient himself or herself or the caregiver can do it. The catheters are soft, plastic, and disposable, meant to be single use, but if you handle them carefully, they can be used often. One catheter can be used up to a week, provided you follow clean technique and wash the catheter before and after with simple soap and water. Clean technique, as I mentioned, and abundant use of local anesthetic jelly makes catheterization easy. A common question is, would I catch an infection? No, not really. Chance of infection is far less in a patient requiring bladder drainage than if the same patient were to use an indwelling catheter. That means the catheter fitted to a bag. However, many MS patients can actually have an indwelling catheter fitted. For example, if they are going out on an outing for a whole day, or maybe if they're going out on a vacation, they can fit themselves with a catheter and simply remove it once they're back home in their familiar environment. How can one prevent UTI? So first is to keep the urine area clean. If you're using clean intermittent catheterization, follow clean technique. Make sure you change your diaper at frequent intervals. There are patients who use a diaper the whole day, and the diaper can actually get badly soiled. It can affect the skin, and of course, the stagnant urine in the diaper is a very fertile ground for bacteria to grow. If you do have urinary infection, which means in addition to your usual symptoms, you suffer from burning, consult your doctor, and more so if you're running fever. These are COVID times, and particularly for MS patients, I would say if you start running fever, it's important you rule out that you're not running, or rather you're not suffering from a urinary infection. Can I use my own home remedies? Yes, you can. That is simply drinking enough water to keep the urine dilute, drinking solutions to make the urine alkaline, and there are proprietary solutions available in the market. And if a specific antibiotic has worked in the past, without waiting for the doctor's help, if you're very sure it is urinary infection, you can actually self-treat. So let's understand, most urinary issues in MS can be managed with very simple techniques. Most important point is it very rarely leads to a major kidney damage. That is all that I have to say in a nutshell. So thank you so much. I hope I have clarified some of the doubts which may be there. I'll stop sharing my screen. And Dr. Bhatkande, are we going to go to...
Yes, I think Dr. Katrak will take this forward. I mean, I think he wanted the questions at this time, sir.
Yeah, I think thank you very much, Adi, for a very lucid and a simple lecture on how to manage problems of the lower urinary tract in patients of MS. She's quite rightly mentioned that upper urinary tract infection is very low in such cases. And that is the most dreaded complication that one can have. When you have urinary tract infection, it can go up along the ureters, affect the kidneys. That can result in kidney failure also. So that is a danger which is very meek, very low amongst patients of MS. Now I'll hand over the thing to Dr. Rekha Bhatkhande to take the questions that may have come up. I see that there's only one question asked.
Yes,
Yes,
sir.
can I answer?
Yes, please go ahead.
I have read the question. Actually, I think my next colleague, subsequent speaker, is far more competent to answer that. But from urological point of view, the answer is simple yes. Provided you know how to use a tampon, you don't forget to remove the tampon on time, follow clean precautions, and do the urinary catheterization if that is also part of your MS issues, exactly the way you would do it otherwise. Whenever there is a tampon inside, the important step is to make sure you change it on time. Apart from that, there is nothing special in MS patients. I can see two more questions.
Yes, please take them, please take them. One is, I think, barrier cream, and the other is,
Is there a possibility of urinary bladder blast? Thank goodness, no, there isn't. Bladder is such a forgiving organ that it would never blast, but it blasts outside. You know, when the bladder leaks, it is actually blasting outside and it will not usually blast inside the body. So if an MS patient holds urine for too long, you will be uncomfortable. And if you're one of those who doesn't leak, then you will have enough warning that your bladder is crying for attention. If you can't pass urine on your own, then please, this is the patient who may be in need for intermittent catheterization. Can you suggest the name of any, I think what you mean is barrier cream, not carrier cream? You know, there are no fancy creams, but any oily substance which produces a layer on the skin is good enough to prevent the skin from getting affected by the moisture. These barrier creams, let me tell you, are not actually having any antiseptic or antibiotic properties. So you could use, say, simple Neosporin ointment, or you could use simple coconut oil also. Anything which creates an oily layer and keeps the water away by making a fat kind of lipid kind of barrier in between. What should one do if one gets frequent UTI? The answer is simple. Find out why is one getting frequent UTIs. If you're somebody using a diaper, change the diaper frequently. If you're somebody using a catheter, then yes, change your catheter, use a new catheter every time. And in spite of all that, if you still continue to get UTIs, of course, contact your doctor. And this is where a specialist comes in the picture, because you are the person who will need a sonography, who will need a urine culture test. And sometimes such patients need an endoscopic bladder washout or a simple washout through the catheter using an antibiotic solution such as povidone iodine. The last question is, I can't make up.
You know, Anita, people are very perturbed about the urgency that they feel, you know.
Yes.
Yeah, I mean, that's something that both the women and men have, that, you know, feeling that, you know, the urgency. And so how should they be tackling?
So the first thing is that if you have a
what that question means, can I just interrupt?
Yes.
I think sometimes with a urinary tract infection, you start getting flexor spasms.
Yes.
Particularly when the urinary tract is involved.
Yes. So you do get these leg spasms. And in fact, that is an indication that there may be a UTI. So that may be an indirect sign that you need to either get your urine checked if possible, or start an antibiotic if you already know which antibiotic works, or perhaps contact your doctor.
And they're very worried about the IV antibiotics. You know, I mean, what happens when the oral ones don't work, or the...
But Madam, I would just like to make it very clear that MS patients very rarely develop fever with UTI or an infection affecting the kidney. And I very rarely need to use intravenous antibiotics. So those who do need IV antibiotics are best hospitalized, because this is not something which can be done at home. And that is exactly the group of patient who needs to be investigated, because why febrile infection? It may be an independent factor and we cannot ignore that. So the specialist would come in the picture and we would insist on full evaluation, which will involve checking kidney function and a sonography, in rare circumstances, a CT scan, depending on the severity of infection and who needs the IV antibiotic. As regards the leg spasms, once the UTI is corrected, if that is the reason for leg spasms, they should settle.
Anita, very simple question. You said, you have to be very careful about when you drink water and when you eat your food so that you do not disturb your night sleep.
Yeah.
So what time would you suggest that someone should be the last time, the end of the day, what for drinking water? What is the time?
The safe time gap, what we recommend is to avoid drinking any liquids for about 2 hours before bedtime. So if the bedtime is say 10:30, I would insist you finish your dinner before 8 o'clock, and maybe there are some medications that you have to take. So finish all of that by 8:30 and keep your stomach dry till your bedtime. Make sure you use the washroom last thing before going to bed. And this will definitely reduce urinary frequency to half of what it would be otherwise, especially in a young patient. In elderly people, this can be an issue, but that's a separate topic in itself.
Just one question that was asked before, prior to this conference, and that was about the peripheral tibial nerve stimulation, in your spastic bladder. And sir's also there, and you're there. So,
yes. I deliberately didn't touch on that because it would be a lot of information in a short span of 20 minutes. But these are various techniques of neuromodulation. So the neuromodulation techniques can be firstly with the help of oral medication, which we just spoke about. Second is by stimulating these nerves which come from the same spinal area from which the urinary bladder nerves come. And the posterior tibial nerve is located in front of the ankle, and there is a special stimulator which is available, but we don't really use that in India as much as what it is used in the Western world. But for the sake of information, stimulation of this can abort or inhibit the urinary bladder contraction. And this is given in sessions, and abroad, the nerve stimulators are actually available for home usage for the patient also. Talking about neuromodulation, injection of botulinum toxin in the urinary bladder is also one way of controlling frequency, urgency, and leak in patients who have not adequately responded to simple means and oral medication. Madam, you asked about how to control the urge.
Yes.
So a very simple maneuver is, first of all, stop doing whatever you are doing and sit down. This may sound very silly, but if you are in a hurry, that is one thing which will ensure you will leak if you were not going to leak otherwise. So आप जो भी कुछ कर रहे, please stop doing that. Sit down on a chair, take a deep breath, and concentrate on the lower part of your body and pull the motion area muscle inwards and make it tight. This has the ability to actually inhibit or abort the urinary bladder contraction. And you will be surprised when you get up, the urge may be much less, and now you will have enough time to walk to the washroom without fear of any leakage. This is pelvic floor muscle contraction.
But yes, one of our participants has said that when I lie down, getting up from bed, actually, I can't control the urine. So
yes, so what they have, these people have a condition called unstable urethra, which means their urethra opens under the effect of gravity. The same patient is able to control as long as he or she is lying down. And as soon as, especially in women, if they're upright, because we know the pelvic floor is far more delicate and more likely to be damaged during normal physiological events such as pregnancy and delivery. So such patients need to learn to pre-contract. That means before she gets up from the bed, she needs to actually contract the pelvic floor and stand up. All this sounds easy. It's not that easy to do. More so if you're an MS patient, but there is no harm in trying. And this combined with antimuscarinic will definitely help such patients a lot.
Thank you, Anita. That was brilliant. Sir, if you can take it forward.
Yes.
Thank you so much, Anita. So I can see Geeta there. So, yeah.
Yeah, one sec. I'm just obliterating the questions. I think after this very lucid and self-explanatory lecture, we go to the next eminent speaker. And as the previous speaker mentioned, that MS affects females to males in a ratio of 2:1. And it affects females in the early reproductive period of their lives. Therefore, the next speaker is Dr. Geeta Balsarkar, who is a consultant obstetrician and gynecologist. She did her under and postgraduate education from GS Medical College and has done her MD, DGO and MCPS in obstetrics and gynecology. She has a lot of academic positions and activities. She is the current professor of obstetric and gynecologist and unit head at the GS Medical College and Vadia Maternity Hospital, Parel. She is also the clinical secretary of the Mumbai Obstetric and Gynecologic Society. She is a vice president of the Menopause Society. And I didn't know there was a Menopause Society till I read about this. Mumbai branch. And she is the associate editor of the Journal of Obstetrics and Gynecologic Society of India. I think today she is going to talk on specific gynecological issues in MS. Over to Dr. Geeta Balsak.
Thank you, sir, Dr. Katrak. And I invite you to join the Menopausal Society of India. It's a very active society, and we are doing a lot of research on work towards menopause. My topic today is, I have taken a little liberty in changing the topic, is obstetric considerations in multiple sclerosis. We have seen a urinary aspect of it and the gynecological, a little bit gynecological aspect also. Today, I am going to talk to you mainly about the pregnancy, the delivery, and a little bit about contraception in the multiple sclerosis patients. I deal with a lot of I'm trying to change my slide. Yeah, see, as Dr. Katrak has said, we know that multiple sclerosis is more common in women. Female to male ratio, male to female to male ratio is 3:1, whereas before puberty and after menopause is 1:1. So we can see in the reproductive age period, a lot of females are affected with multiple sclerosis. It mostly begins between 20 to 40 years of age, and thus women of childbearing age are very commonly affected. Now, first we have to understand that the probability of conception in multiple sclerosis patient is very low. What does this mean? That means the chance by which a patient of multiple sclerosis will conceive, that itself is very low. They have lot of problem with conceiving, and they have generally fewer children than the general population. This is because of the effect of the autoimmune disease with the multiple sclerosis, the autoimmune disease that is, it also affects the fertility levels. Where there are higher disease activity of multiple sclerosis, it will have lower AMH level. AMH is the anti-Mullerian hormone levels, and these are responsible for the ovulation and the quality of the egg production. So if they have higher autoimmune disease, more amount of eggs are also destroyed along with it, and hence they have a lower chance of conceiving. Artificial reproductive techniques, particularly the use of hormones like GnRH agonist, this will increase the MS disease activity in the short term, that is immediately after using these hormones. And also we should not forget the contribution of symptoms like fatigue, sexual dysfunction. Sex is virtually a very difficult thing for them, and bladder impairment on attempting pregnancy. And sometimes when these ladies come to know that they have got MS, the individual decision to conceive is also being influenced by her disease. So all in all, there is a very less chance that a pregnant patient of multiple sclerosis patient will attempt pregnancy or will agree to attempt pregnancy and then will conceive. Now, overall, when we are talking about managing such a patient, a multiple sclerosis patient who has become pregnant, it's very, very important that obstetrician should be included in the team. There are a lot of important aspects of multiple sclerosis in women. First of all, we have to give them family planning advice to delay or postpone the pregnancy, including giving them oral contraceptives. Or if these patients have become pregnant and they are having symptoms of MS and they need the drug treatment, then we should offer them termination of pregnancy. And if they have finished their childbearing, then they should be given sterilization. Now, the disease modifying therapy, that is the DMT counseling, is very, very important in these women. And some DMTs are very harmful to the developing fetus, and some of them can be used for to modify disease in these women shortly or till the pregnancy is confirmed. And once the pregnancy is confirmed, then they may have to change their DMT. Overall, during pregnancy, there is a decreased risk of the MS relapses. This is very good news, but the relapse risk can increase postpartum. Therefore, pregnancy by itself, the MS women, pregnancy by itself does not worsen the progression of MS. This is one of the concerns of the MS women. They often ask us that if I become pregnant, will my disease become worse? No, pregnancy by itself will not worsen the progress of the disease. And during the time of pregnancy, there is always a reduction in the MS relapses. But these relapses can increase after delivery or what is called as a postpartum period. Menopause or the absence of menses or the cessation of menses at roughly between 45 to 51 years of age, these can cause disease progression in women with multiple sclerosis. We have to keep these points in mind when we treat the multiple sclerosis patient. Now, what is it? In the early 20th century, pregnancy was believed to promote poorer outcome for women with multiple sclerosis and hence was discouraged. Therefore, if a woman had multiple sclerosis, she was advised against becoming pregnant. But this perception changed with the landmark study, which is called as a pregnancy in multiple sclerosis. There is a PRIM study which was published in 1998. After that, we have started allowing the multiple sclerosis women to go through pregnancy and delivery. So what are the recommendations in planning a pregnancy? First of all, contraceptive counseling and spacing of pregnancy is very, very important. The patient should not land up to a doctor with an unplanned pregnancy, especially if they are having multiple sclerosis. And if these patients are visiting at regular intervals their neurologist, they should also be made to visit the gynecologist once a year at least for regular contraceptive counseling and to discuss the spacing of pregnancy. And pregnancy should be a planned decision of all the family members because there may be some other caregivers in a case of multiple sclerosis. So it should be with counseling of all these members. Pre-pregnancy baseline investigations should be done, which are done with any other pregnancy patients and also with multiple sclerosis patients. A clinical neurologic visit and an MRI before pregnancy is completely required, and we have to discuss with the patient and choose a pregnancy compatible disease modifying therapy. Now, it's very important to have treatment and make the patient very stable before she undergoes conception. So treatment stability prior to conception is very, very important when we are talking of pregnancy in multiple sclerosis patient. Now, what are the drugs used in multiple sclerosis? Majority of the medications used in multiple sclerosis are of the FDA category C for use in pregnancy. That means the risk is not ruled out. No studies in humans, but potential benefits may warrant the use of drug in pregnant women. There are limited data on both the safety profiles during pregnancy and risk to the developing fetus. An exception is the Copaxone, that is GA, which is FDA category B. So it's slightly better drug which can be used in pregnancy. Now, GA, IFNB preparations, dimethyl furan, natalizumab treatment should be used in pregnancy only if we know that the benefit outweigh the risks in these multiple sclerosis patients. So if these disease modifying drugs are surely going to modify the disease and make the day-to-day living of these patients very much better, only then they should be used in pregnancy, because all these drugs also have got effect of toxicity on the fetus and causing the anomaly. Now, coming to various modalities of how we are going to manage this patient. In pre-pregnancy counseling, we have to tell the patient that there is no effect of multiple sclerosis on fertility. If they have conceived, do not routinely defer DMT. Some patients say, oh, I became pregnant, so I have stopped all my disease modifying drugs. No, that is not correct. Just because they have become pregnant, they should not stop any medicines they are on. They should go to their neurologist, they should go to their obstetrician and change the drugs. Ideally, they should be prior stabilized with drugs that are, compatible with pregnancy, and then they should achieve pregnancy. They have to consider pregnancy does not affect the long-term disability outcome in a multiple sclerosis patient, and relapse risk during and after pregnancy have to be counseled to the patient. Now, next, when we talk about the obstetric part, now that the patient has become pregnant, just because they are pregnant in a young patient and they have multiple sclerosis, they automatically do not become a high risk pregnancy. They can receive methylprednisolone for the relapse treatment. Vitamin D supplementation is very, very important in the multiple sclerosis patient. Multiple sclerosis by itself should not influence delivery or analgesia outside the disability consideration. If the patient has got severe disability considerations, then we have to think that whether she can be given position, whether she can undergo vaginal delivery, or will she require any analgesia. But otherwise, in a young woman with not many years of disease, and if the disability is not much, we can allow a normal delivery. Epidural or diazepam for troublesome spasticity to labor, there are a lot of papers on this and has been considered. Now, what happens when these patients deliver and then they go into the postpartum period? So we should support breastfeeding along with the treatment consideration. Methylprednisolone should be used if these patients are likely to get relapses, which is very common in the postpartum period. And remember, we have to remember that these patients are at increased risk of postnatal depression. As it is, postpartum blues are very common. And nowadays with COVID-19 and with a lot of people at home, depression is a very big factor, especially in the postnatal period. Then they have to be given symptomatic treatment as to what they are having. Like if they are having urinary tract infection, they have to be tackled accordingly. And the risk benefit balance on individual basis has to be discussed between use of antibiotics and the effect of the drug on the fetus, the use of the disease modifying therapy in multiple sclerosis and its effect on the fetus. All these have to be considered. Their bowel, bladder, all their complaints have to be tackled with, and they have to be given symptomatic treatment. Now, the disease modifying drugs, whatever is used, they do not interact with oral contraceptive pills. So if these patients, multiple sclerosis patient, want contraception, they can be given contraception very easily, and they do not interact with the disease modifying drugs. But if these patients are on disease modifying drugs and they want to consider conceiving, some of these drugs require a washout period before conceiving. Hence, we have to consider to wait for 3 months to 6 months before these drugs get washed out, and then these patients can be allowed conception. And in these patients who are already on disease modifying drugs and have conceived, we may have to consider additional monitoring of the patient and the baby for any problems. What are there are a lot of therapies that are available. Some of them are included here. Copaxane or IFNB preparations, they are safe to continue until conception. There is no evidence that they cause harm to the baby, but if stopped, 3 to 12 months it takes to reach full efficacy postpartum. There are a lot of benefits that the breastfeeding can be allowed on the treatment. They outweigh the risk. So when patient is on Copaxane or IFNB, this can be given until they conceive, and if required, they can be allowed to be continued a little bit during the pregnancy also, and during breastfeeding they can definitely take. Teriflunomide is a that animal studies have shown a lot of teratogenicity, potential exposure in females where transfer in seminal fluid. 2 years is a washout, or even with accelerated elimination, it may take up to a year. Unplanned pregnancy, it's a very high risk, and accelerated elimination, we'll have to see. Breastfeeding is completely contraindicated. Natalizumab, high risk of relapse, rebound if stopped. No specific pattern of birth defects. We have to consider treating in pregnancy, and low absorption in breastfeeding. Alemtuzumab, it is also, we have to monitor for autoimmune disease during pregnancy and do not give when breastfeeding. Dimethyl fumarate, we have to consider the effect of GI upset on oral contraceptive pills. Dimethyl fumarate causes GI upset, and hence it could these could affect the oral contraceptive pill absorption. There is limited data in pregnancy, and breastfeeding is contraindicated. Fingolimod, limited data, 2 years or 12 months washout, unplanned pregnancy, we have to immediately stop, and these patients are at high risk. Breastfeeding is contraindicated. The cladribine, teratogenic in the both mother and the fetus, we have to avoid pregnancy for about 12 months after treatment, and breastfeeding is completely contraindicated. Ocrelizumab, we have to avoid pregnancy for 12 months. Unplanned pregnancy, we have to immediately stop, and breastfeeding is contraindicated. Now, what happens to relapses? Natural history studies are mainly in the untreated populations. Relapse frequency definitely reduces during pregnancy. During pregnancy, patients feel very better because they do not have any signs or symptoms of MS. A quarter of women will experience relapse during the first 3 months of postpartum. During pregnancy year, that is, if we take the complete 9 months of pregnancy and 3 months of postpartum, the risk of the relapse is same or overall as that of a woman with MS who is not pregnant. Therefore, in 1 year, a woman with MS who is not pregnant, how many relapses she will get? The same amount of relapse they get, but the first 9 months of pregnancy, they are very happy. They don't have much signs and symptoms. And the next 3 months, they can have a lot of relapse. Relapses can be treated with corticosteroids during pregnancy and even during breastfeeding. Now, what are the in which patients will have a lot of relapse, or we can anticipate relapse? Who are the patients who are at risk of relapse? Whenever use of GnRH agonist has been done for assisted conception, these patients are at high risk of relapse sometimes during pregnancy only, and later on in the postpartum period. But however, knowing that these patients are at high risk for relapse, we should not deter women with the MS from seeking assisted conception when this is indicated, because it may be their only chance of having a child. In vitro fertilization, if this is done, then they are at a high risk of relapse. Some symptoms may worsen, like fatigue, balance, bladder symptoms, particularly in the later or the third trimester of pregnancy, they are more frequent. Now, Bell's palsy, entrapment neuropathies, for example, like carpal tunnel syndrome, meralgia paresthetica, are more common in late pregnancy and may cause new symptoms. However, we should keep the MS relapse in mind as one of the differential diagnoses, and the other things that we should know, that there could be other reasons for these in addition to MS. Now, does MS affect pregnancy? Having MS actually should not influence obstetric management. For example, whether they can have epidural or a spontaneous vaginal delivery. If the patient is young and the MS has been recently diagnosed, they can very well go through vaginal delivery and have epidural or any other patient. Although if these women are elderly, they are like more than 40 years of age, they have significant disability, for example, like spasticity, these have to be taken into consideration while planning the obstetric care. Now, what is the management during pregnancy? The standard advice for all pregnant women, with particular emphasis on not smoking, performing pelvic floor exercises, and taking recommended supplements. Performing pelvic floor exercises is very, very important. It helps a lot in their bladder control symptoms that they come, especially during the third trimester. So they should be encouraged to have a normal life, normal walking of about 30 minutes, performing pelvic floor exercises. All this should be encouraged during pregnancy. The MS team should be notified as soon as possible if a woman with MS becomes pregnant, so that they can provide appropriate support and liaise with the obstetric team. No additional obstetric scans are required. Just because a woman has MS, only one second trimester malformation scan should be done, as it is done in all other patients, to see if they have got any anomalies, and then the rest of the normal scans. Now, neurological management, MRI is not contraindicated at any time during pregnancy. So if a patient has relapse or any of the symptoms reappear, then we can definitely do MRI during pregnancy. However, gadolinium contrast media should be avoided whenever possible. The woman should be able to care for the baby and herself. More specifically, if a woman has leg problems or spasticity or severe weakness of the pelvic muscles or legs, then she should be referred to a physiotherapist early in pregnancy to work collaboratively with the obstetric team to optimize labor and delivery. To be able to care for her during labor and delivery, we may need a neurophysiotherapist who will help us in helping this patient. Now, what about delivery and anesthetic options? Troublesome increased spasticity during labor may be controlled with benzodiazepines or an epidural anesthetic. MS should not influence the mode of delivery or analgesia or anesthesia unless the disability is very, very significant. Women with spinal cord involvement or loss of sensation below T11 may not be aware of the onset of labor. Sometimes they are not aware, they don't get that pain, and they may not be aware of the onset of labor. They should be taught to look for symptoms that are indicative of labor, including an increase in spasticity, gastrointestinal upset, flushing, back pain. They can simply put the hand on the abdomen and they can feel the hardening of the uterus. This is also one of the signs of labor. Obstetric team should be aware that for women with MS who have severe spinal cord disease, autonomic dysreflexia should be considered in the differential diagnosis for preeclampsia. Preeclampsia, one of the things we see is a knee jerk. So if we see knee jerk in these patients who have spinal cord disease, we should remember how to interpret this. It has to be interpreted slightly differently than in the other patients. Now, what about the postpartum relapse? The protective against the postpartum relapse, the preconception disease modifying use. If before the patient becomes pregnant, she has taken adequate disease modifying therapy and she is very much in control, this will protect against postpartum relapse. If there were lower disease activity before conception, this will reduce the postpartum relapse. Early reinitiation of the disease modifying therapy as soon as the woman has delivered, if we reinitiate the disease modifying therapy, this will prevent the postpartum relapse. And potentially we have to see that we are promoting breastfeeding, and particularly exclusive drugs have to be used. Now, what are the risk factors associated with postpartum relapse? Higher disease activity before conception in the preceding 12 months if the patient has had higher disease activity even during pregnancy if she's had relapses, higher disability level at the onset of pregnancy, and longer washout period after the discontinuation of the high efficacy disease modifying therapy. No effect on the postpartum relapse as to the age of the patient, the number of prior pregnancy, if this is a first pregnancy, second pregnancy, or the third pregnancy, whether it is a male child, female child, whether the patient has undergone normal delivery, cesarean section, they do not have an effect on the postpartum relapse. Use of epidural anesthesia, postpartum use of immunoglobulins or steroids, they all have no effect on the postpartum relapse. So what should be the postpartum advice given these patients? They should be compulsorily educated to breastfeed. The norm in India is to breastfeed. If they are uncertain whether exclusive breastfeeding can reduce postpartum relapse rate, so some of them ask, if I breastfeed completely, will my relapse go off? That we cannot say, but breastfeeding is very important to the baby, and at all times they must be encouraged to breastfeed. Women who are breastfeeding, they should be advised to consider storing of the breast milk in the freezer in relapse associated disability or severe fatigue in case they need to be prescribed a medication that is not compatible with breastfeeding. There is no indication to stop breastfeeding if the steroid or methylprednisolone is used to treat a postpartum relapse, other than if relapse associated disability that itself prevents the breastfeeding, then she cannot breastfeed anyway. There is no evidence to support regular methylprednisolone in the postpartum period to prevent relapse. Some patient ask, if I start taking methylprednisolone, will it prevent my postpartum relapse? There is no evidence to say that regularly taking methylprednisolone in the postpartum period will prevent the relapse. A lot of patients need help in the postpartum period to take care of herself and the child. Immunoglobulin should not be given for postpartum relapses. Women with MS should be asked to take vitamin D, and their infants also should be given vitamin D in line with the standard advice. The neuro multidisciplinary team should provide advice to midwife and a health visitor as required. The women with MS may require additional support from a family, friends, and multidisciplinary team, especially in the postpartum period. The MS team and midwife should help her to plan this in advance. Even before she delivers, we have to start talking to them. How are you going to manage yourself in the post-delivery period or in the postpartum period? Now, postpartum blues or depression, there is an increased risk of postpartum depression in mothers and even in fathers with MS. The MS services, midwives, health visitors, GP, all should be made aware of this, and they should offer appropriate support as required. The MS team should ensure that the person women with MS and their partner are aware that these patients can slip into depression, the signs and symptoms of postpartum depression, and how to get help if they are concerned at any time. Now, cord blood banking, there is insufficient evidence at present to recommend routine umbilical cord blood collection and banking for women with MS for future MS related treatments like the stem cell therapy. As of now, there is no evidence. So we do not, for the sake of MS, or we do not ask for the cord blood banking. So to conclude, treatment with disease modifying drug should not be delayed until a woman with multiple sclerosis has completed her family. Even if the woman is not willing to take it during pregnancy, we have to counsel her and see that she takes a disease modifying therapy if she requires it during pregnancy. We have to consider the possibility of pregnancy when prescribing drugs to a woman with MS or the childbearing age. This is true of any woman, but more so if she has MS and she is of the childbearing age. Relapse rate reduces naturally during pregnancy. The 9 months of pregnancy, the relapse rate reduces. So many women with MS, they choose to stop the disease modifying drugs when they become pregnant. However, for those with very active MS, treatment throughout pregnancy should be considered. If relapse does occur, corticosteroids can be given during pregnancy and while breastfeeding. Having multiple sclerosis does not automatically make the pregnancy high risk and should not in itself limit the birthing options. If the woman is not having major disability, she should be allowed to undergo a vaginal delivery. If only the mother is healthy, then the baby can be taken care of properly. And since it's a progressive disease, don't tell the patient that don't conceive now, come after 6 months and then we can discuss conception. You're only delaying the patient and the disability will only progress and she will not be in a better position tomorrow than what she is already today. Having said that, optimization of the mother is very, very important. So controlling the disease prior to pregnancy is very important. Many patients have difficulty in conceiving. We have to keep that in mind. When we advise them to have children, MTP should not be easily offered. If they have conceived accidentally or even after taking drugs, we should not offer them MTP because that may be their only chance of conceiving. And then this may be the only chance of having a baby. They need help very much after delivery, and which may be more stressful for them than the pregnancy itself. We have to keep that in mind when we talk to them about it. And thank you for a very patient hearing. I would like to thank Dr. Katrak and Dr. Rekha Bhatkande for giving me this opportunity to speak in front of you. Thank you.
Thank you, Dr. Balsalkar. I think you've covered the subject extensively.
Beautiful.
And I think many of the cobwebs in my mind also regarding pregnancy and postpartum period have been clarified by you. Now, I think I see about 10 questions and I hand over the mic to Rekha to take the question answer session, or if you would like to check on the question answers.
Yeah, I'm seeing
yourself.
some of them, yeah, but
I think quite a few of them are talking about, very heavy menstrual flow after, these disease-modifying drugs and, whether they are linked, whether it is the same thing.
no, see, the disease-modifying drugs have no effect on the menstrual bleeding. That could be because if they are in that particular age, like, wherein the hormonal problems arise or there is a lot of estrogen, then in that case, this may be not related to the MS or it is not related to the drugs, treatment of MS. It may be age related to a certain extent, and it may middle age, it is known, they are known to have bleeding irregularities. So it may be like any other patient who doesn't have MS.
Geeta, you said you've seen menopausal women and the MS becoming worse. What about premenstrual symptoms? In those who have very severe premenstrual symptoms. I mean, could that also worsen MS symptoms by themselves?
See, it has not been reported that MS patients have worse premenstrual symptoms, but the MS patients, by the virtue of having those signs and symptoms of MS, they have very low tolerability. So even little bit of sort of premenstrual symptoms which any other patient would have easily ignored, these patients tend to feel it like as if it is little sometimes they get confused it with the symptoms of MS itself, and then they feel that I'm having a lot of issues, but by itself PMS is not altered by, or is not affected by, or is not increased in MS patients.
So those who are already on, these disease-modifying drugs, and they have now shifted to rituximab or whatever, but you have said that do not do any extra scans. But how will you know about fetal toxicity in these patients?
See, it is if you know the pregnancy, the first trimester, the second trimester, and the third trimester, up to 16 weeks, the development of the fetus is already over. So if any anomalies, or if any what do you say, the problems or anything has to occur in the development of the baby, up to 16 weeks it is already over. So doing a scan repeatedly after 16 weeks is not going to help us. It would be already detected between 16 and 18 weeks if there are any toxicity to the fetus. After that, what happens is only the growth. So then we consider them as any other patient. So till 16 to 18 weeks, they have to be monitored for development of anomalies in the fetus. And after that, they will be monitored as any other patient.
May I say something?
Sorry, sir. Please, go ahead.
Please, may I say something about premenstrual person? Yes. I think with water retention, sometimes the flexor spasms of spasticity can become worse. And many patients attribute a deterioration in their MS because of the flexor spasms. I think sometimes just giving them plain simple diuretics during the premenstrual period sometimes allays all that increase in spasticity.
Another thing, Geeta, how often have you seen autoimmune thyroiditis because of all these drugs, in pregnant women? Because then again, you need to look at the fetus and possible thyroid dysfunction. These drugs
autoimmune thyroiditis due to disease-modifying drugs of MS. I'm not able to come in contact.
So?
I'm not aware of that.
Yeah, okay, fine, wonderful.
Immune thyroid. Yeah. I think dimethyl fumarate can produce a certain amount of dysfunction of the thyroid function, TSH.
In the mother or in the baby?
In the mother.
Mother.
We are not taking fetal blood, so we don't know. So in the mother, it can produce, but that is not reflected clinically in any obvious symptoms of hypothyroidism.
I think that was a great talk, Geeta. Sir, is there any summing up you would like to do?
Yes, I think.
Madam, I'm very, very, I feel one thing, please do not offer MTP. No obstetrician should offer MTP to these patients, because as it is, they find it very difficult to conceive. And then I get some patients who have undergone MTP and then they come crying, and it's very, very difficult to counsel these patients.
I mean, Geeta, I've learned two things from you. One is that if a MS patient becomes pregnant, help her through a pregnancy. And the second is that,
that might be the only chance that she will ever have a baby.
And the second is postpartum depression is there, and we need to look at it very, very aggressively, especially in our multiple sclerosis patients.
Madam, so far in India, we used to have large families where they had a lot of emotional support and elders in the families who used to take care of it. But now things have changed. In the last 10 or 12 years, we are having only husband, wife, looking after the kids, and postpartum depression is really very big in obstetrics today. Not only in MS patients, even otherwise, and more so if they are MS patients, they forget to take their drugs, whether they have taken their drugs or not. The baby is waking them up every 2 hours. They are not able to get an 8 hour sleep, at least for 3 to 6 months till the baby is weaned off the breastfeeding. So it is very, very difficult, in these patients, and depression is very common.
I'd like to ask you a question. In patients who are on disease modifying drugs and very dependent on them, very well controlled on them, and this is a practical difficulty that I had recently. I advised no further pregnancy and tubal ligation, or if she insisted on pregnancy, I offered them surrogate pregnancies, but that female was so emotionally charged that she refused surrogacy and wanted to bear her own child, which reflects the psychological
Society.
framework of patients with MS. So I entirely agree with you that offering medical termination of pregnancy is a big no-no in such cases. Their emotional makeup is such that they themselves know, okay, this may be the only chance for me to have a child. And I think we should support them throughout the pregnancy. I think pregnancy offers a certain amount of remission of symptoms.
Relief. So they are relieved during the pregnancy. The problem occurs postpartum.
Postpartum. So that is the period in which they require a lot of support. Okay. Now, I'd like to conclude the session before I hand over the mic again to Rekha. I think Dr. Anita Patil gave me a very nice saying. You have a happy and a very unhappy urinary system. I think similarly, Dr. Geeta Malsalkar also told us about a very happy pregnancy and what you should not do to make the pregnancy any unhappy. And I think both the speakers really spoke in tandem with each other, outlining all the problems that are very classically associated with females in the reproductive years of life with pregnancies and urinary tract problems. I think I myself would like to thank you all both personally for beautiful lectures.
Thank you, sir.
And I think, Anita, I would like to have your first 2 slides about a happy and an unhappy.
And there is no copyright issue because I have hand-drawn them, so they're all yours.
Fine. I can try my own hand at it. In my lecture on urinary neurogenic bladder, so I can try my own hand at it.
Yes.
But thank you very much, both of you. And I think having said that, I'd like to hand over the mic back to Rekha. The honors regarding, I think we have 10 minutes more time.
Yes, there are any questions?
Yeah. No, and sir, we would like you to also give us a few bit of a, you've done so much extensive work on neurogenic bladder. So perhaps we could hear from you too.
See, I think the points that I'd like to make about a neurogenic bladder in MS is that the most important consideration is quality of life issues. And Dr. Anita Bapat Patel outlined a very beautiful slide on how it affects the quality of life and how you combat the quality of life issues. One must also remember that when you have frequency of micturition in these patients of MS, they also have mobility problems and they cannot reach the toilet in time. If the frequency is very severe, I sometimes recommend them having a commode by the bedside in which they can empty at night, particularly at night. The frequency of micturition, if you don't have adult diapers, etc., disturbs the sleep pattern also. And it increases, and with the wetness that it occurs, with nocturnal incontinence, the flexor spasms become more and they become very painful. And sometimes not only do we have to treat the neurogenic component of the bladder, but we have to also treat the spasticity more at night. The fear of over-treating the spasticity is that the knees buckle under the weight.
Yeah.
Because when they become erect, the knees buckle under the weight. So if they have a commode by the side of the bed, they don't have to travel a certain amount of distance and they can manage that.
So one of our participants has said that, night catheterization. I mean, you put in a catheter for the night. I mean, is that recommended or?
No, I personally wouldn't recommend it, but I think Anita is raising her finger, so
Yes.
I'll leave her to answer.
So yes, in fact, ma'am, we do that in selected patients where we leave an indwelling infant feeding tube. And that is not an indwelling Foley catheter. In fact, this is a norm in a lot of pediatric voiding dysfunction that we deal with, which is not related to MS. But in MS patients also, if night frequency is an issue, too much of an issue, then perhaps a tube in the bladder left open into a diaper, so the bladder stays empty. The bladder stays empty, and obviously because it doesn't fill up, it doesn't wake up the patient. And in addition, maybe a very mild anti-anxiety kind of medication, provided it doesn't disagree with the MS tablets, and a restful sleep with this simple maneuver will make a patient much fresher the next day. So we do recommend, though very rarely, an indwelling infant feeding tube kept open in a diaper. There is no bag here. And the patient can freely turn in bed without the fear that, the bag will get disconnected, pulled, etc. So yes, that can be done, but rarely. And as regards intermittent catheterization in MS patient, there is a peculiar entity called what is normally the muscles and the urinary bladder are in sync with each other. So they are synergic. That means when the bladder wants to push the urine out, the muscle opens or the door opens. In MS patients, we have this peculiar condition called dyssynergia. That means the bladder and the door may not work together in synergy. Now, this does become a problem for catheterization. And sometimes in MS patients, as the catheter tip touches the urethral opening, the external sphincter literally shuts, or the outlet shuts and goes into a spasm. And we have patients saying that, doctor, I try putting the catheter, it doesn't go in. And they are catheterizing the urinary passage correctly. The reason this happens is because of spasm, and the treatment is simply wait. Simply wait, watch, use adequate lubrication, and have one more attempt. Not use a larger catheter, but simply one more attempt, take a deep breath, and the second time around, usually the catheter will go. So that's a little trick. Thank you.
What about using a tampon together with diaper at night?
Yeah, Dr. Geeta, do you want to take that?
What are you saying? Using a diaper instead of a diaper?
Tampon sites in the adult diaper for increased frequency and
I thought you were talking about tampon during periods.
Periods, no.
Not during periods. No, not during periods. Only for increased frequency.
No.
Tampons are put in the vagina.
Because
no external type.
Yeah, no, tampon is used sometimes in patients who have a totally wide open outlet and very severe form of what we call as intrinsic sphincter defect, but that is in a non-neurogenic scenario. And in some patients, we make use of that as a intravaginal support to the bladder neck. But in MS context, since the cause of incontinence is totally different, tampon unfortunately would not really have any utility.
I have one question for Dr. Anita. The
Yes.
third trimester of pregnancy and MS patient, they come with lot of urinary problems, you know, lot of symptoms, repeated infections, dribbling, lots of issues. Is there anything other than Kegel's exercises and routine pelvic exercises that we can do to reduce their incidence of infection? As it is a normal healthy patient also has got a lot of infections and urinary problems in the third trimester.
Recommend one additional step. You already know what to do, but one thing which we recommend, MS patients may have an abnormal urine report as a result of contamination of the perineal area, and their bladder symptoms may be due to MS itself, and of course the third trimester uterus pushing everything out. So though the symptoms will sound like they have a UTI, it may not actually be a UTI, and it sometimes helps to collect a catheter sample of urine. Now, why do we do that? That is so that we're very sure that the so-called UTI is actually also present in the bladder sample of urine, and not just as a result of a very small volume trickling out, falling over the introitus, and then hitting the container, and then reaching the lab, which will show a fair number of pus cells and organisms. So if it is that important to prove UTI, do collect a catheter sample in an isolated case, but otherwise there is no magic cure really, unfortunately.
Fine, thank you. I think we are approaching 5:30, and I think since we have not heard Sheila Chitnis say a single word,
Yes.
I would like to invite her to say a few words.
Sheila, I think you can take over the thank yous. You know, you can thank everyone because we would love to hear you. Please go ahead, Sheila. Anyway, before she comes in and talks to us, I'd like to thank our chairpersons and Dr. Katrak for, because I know tomorrow he's got a mega event at Just Look. And thank you so much, sir, for sparing your time and to be with us. I thank Anita and Geeta. I think you're brilliant in what you have told us. I mean, absolutely brilliant. And I'd like to thank Bhavesh and Manasi of the Chaugule Medi Consults who have been, who had, handheld us through this whole seminar. And where's Sheila? Where's Sheila? Sandeep, where's Sheila? Sheila,
I think
unmute
Sandeep
yourself.
has also left.
Unmute yourself. The last word goes to you.
I think there is some problem with connectivity.
Okay. Can she talk with you, or are you somewhere else? Okay. Sandeep, anything you can say on behalf of Sheila?
Hello.
Oh, well, wonderful. Go ahead, please.
Hello.
Yeah, we can hear you, Sheila.
I can't see you.
Your connectivity is not there, but please, we can hear you. We want to hear you.
Okay, then I would like to thank all of you. You were really wonderful. This session was very wonderful.
Beautiful. Beautiful.
I think concluding, I think we should say thank you to all the organizers, all the speakers, and Mansi and Bhavesh for an excellent webinar. I'm always available to MSSI when they need my help. Okay, so you don't have to thank me. I'm part of the MSSI. Having said that, I think we can conclude this webinar because it's exactly 5:30.
Thank you so much, MSSI.
Thank you, sir. Thank you.
Thank you.
Thank you so much.
And I thank the audience. Wonderful audience. Thank you.